Okay, start Praveen.
Yes, sir.
Share the screen and start presenting. Or you are presenting orally.
Sir, I'm presenting, sir.
Okay, yeah.
A 14-year-old female came with chief complaints of lump in the left breast since 6 months. Patient was apparently normal since 6 months back. Then on self-examination, she noticed a lump in left breast, which was insidious in onset, and there was no noticeable change in size since then, and it was not associated with pain. No history of nipple discharge, no history of lump in other breast, no history of chest pain or breathlessness, no history of abdominal pain, no history of backache, no history of headache or vomiting, no history of loss of weight or appetite. Coming to past history, she has no medical comorbidities and had undergone tubectomy 15 years ago. And personal history, she takes mixed diet, have a normal sleep pattern, had normal bowel and bladder habits, had no history of smoking or alcohol intake, or no history of OC pills intake. She attained menarche at 15 years of age, and she has 4 live births. First child birth at 22 years of age, and all of them were breastfed for 1 year, and attained menopause 3 years ago. No history of similar illness in family members, no history of breast or ovarian malignancy in the family.
Okay, wait.
Yes, sir.
Nikita,
Yes, sir.
anything else you want to know in the history?
Nothing in specific. So I think he covered all the points.
Samir,
Sir, her personal history, sir.
personal history has mentioned, no, everything. Anything he has missed, you think?
OCP.
He has mentioned everything. Tanya is not there, no? Is Tanya there or she is not?
Sir, ma'am is not able to join today.
Okay, right, right. Nitya, anything in the history that you would want to ask?
Just to rule out any trauma to the breast, sir.
How will that help?
Sometimes traumatic fat necrosis also can present as a lump.
Okay. See, Kritika, anything you want to comment on the history, or is he taken all points? Kritika, are you there?
I think she
saw-
has left, sir. Yeah, she
I
was
think-
there and I think she's not there right now.
Okay, right. See, the only thing I think he should ask is any previous history of any symptoms in the breast, previous lumps in the breast, previous history of any surgery in the breast, which I think he is not mentioned, but that is something you have to mention. Otherwise, I think the history is fairly comprehensive. But all of you remember, in the exam, you will not have the benefit of a PowerPoint presentation. So you should be able to present the history in a methodical fashion. So practice, presenting in a methodical fashion, and also be prepared for a concise presentation as well. Because suddenly the examiner may ask you, give us positive history in the positive findings in the history. You should be able to just reel out 3 or 4 positive points. Okay, go to the
Yes.
examination.
Coming to general examination, patient was conscious, oriented, moderately built and nourished. There was no pallor, no icterus, no sinuses, no clubbing, no pedal edema, no general sniffing. Vital examination, pulse rate was 78 beats per minute, BP 130 by 70 mm of Hg, saturation was 98% on room air, and she was febrile at the time of examination. Coming to local examination, that is examination of breast and axilla. After getting informed verbal consent, patient was exposed adequately in a well-lit room with a female attending in sitting position with arms by side, raised above head, and in leaning forward position. Inspection of left breast. Left breast appears to be in symmetry with right breast in terms of size, shape, and nipple position. There was no nipple discharge, no nipple retraction, no lump was seen, no dilated veins was seen. FNS scar seen at upper inner quadrant of breast, and no other skin changes were noted.
Just a minute. How do you know it's FNAC is not a true cut biopsy?
Sir, there was a small needle mark, sir.
I would just say,
Biopsy is called seen, sir.
yeah, no, was there a scar or was it plaster that they had put?
The scar was seen, sir.
Okay, recent procedure, scar of a recent procedure present wherever that is.
Okay, sir.
Don't commit to unless you are absolutely certain that it is FNAC. Um, you know, so don't commit to saying it is a FNAC. Just say, recent diagnostic procedure on the left breast. Scar of the recent diagnostic procedure on the left breast. I think that would be safer to say. Okay.
Okay, sir. On
Because
palpation, yes,
these
sir.
days, if possible, you would always want to do a true cut
Core
rather
needle
than
biopsy,
FNAC,
yes, sir.
core biopsy, which is why you better to know. Then you will invite question: why did they do FNAC? Why didn't they do thing? So all those unnecessary controversies you might invite. Okay.
Okay, sir. On palpation of left breast, there was no rise of temperature. A single lump of 2 by 2 centimeters in left upper inner quadrant of breast at 9 to 10 o'clock position was palpated, which was irregular margins, hard in consistency, and no tenderness. Lump was moving along with breast tissue, and it was not fixed to skin or underlying muscle or the chest wall. There was no nipple retraction or discharge. No lymph node was palpable in the left axilla and left supraclavicular fossa. Examination of right breast was normal with no palpable lump, and right axilla and right supraclavicular fossa showed no palpable lymph nodes. On systemic examination, CVS S1 S2 had no murmurs, respiratory system bilateral normal vascular breath sound had, CNS no focal deficits, GAT abdomen was soft, no organomegaly, spine no tenderness. To summarize, a 49 years old menopausal woman with no comorbidities presented with 2 by 2 centimeters of lump in upper inner quadrant of left breast with irregular sufferance and hard consistency with no palpable lymph node of left axilla for 6 months. And my probable diagnosis will be of carcinoma of left breast with TNM staging of T2 N0 M0, which comes under stage.
Okay. It's fairly straightforward. There is no ambiguity. So there is no need for offering a differential diagnosis because clinically it feels, as far as what I can hear from your examination, that it is a hard, irregular lump. So I think no need for any controversy there. Don't think you need to offer any differential diagnosis. Okay. Um, Presentation wise, Nitya, anything, um, any questions or clarifications you want? Was there intrinsic mobility, Praveen?
Yes, sir, it was moving with breast tissue, sir.
So it was not independently mobile. When you fix the
No, sir.
breast tissue and
No, sir,
move it,
not mobiles. Not mobiles, sir.
not a mobile.
Yes, sir.
Okay. But it was not fixed to the
Not
underlying.
fixed to skin, not fixed to chest wall or pectoral,
Yes.
underlying muscle.
Okay. So how did you demonstrate the fixity to the underlying muscle?
Sir, first we'll make patient in sitting position. Will mobilize the breast across the to and fro across the chest wall. If the breast cannot be mobilized, then it is fixed to chest wall. And if it is mobilizing, then we'll ask the patient to uh, keep arms pressing against the waist. Again, we'll move the breast to one position. If it is not mobilizing, then it is fixed to pectoralis muscle. If it is mobilizing, then it is not fixed.
So in this case, it was not fixed to the chest wall or to
Both
the
chest wall or
pectoralis.
pectoralis. Yes, sir.
Okay. Nitya, any questions or clarifications you want?
From history wise, no, sir. History and
No, history is
examination,
already finished.
no, sir. The examination, it's fine, sir.
Nikita?
I have a small doubt, sir.
Hmm.
As for the TNM staging, sir, here, 2 into
Hmm.
2 centimeters, should we consider it as like 2 centimeters as the diameter, sir, here, like, because 2 to
Yeah,
5 centimeters is a different stage, up to 2 centimeters is a different stage, right, sir?
correct. Yeah.
So,
So
You
so
said
2
2
2
here,
centimeters.
is T1.
So I think
Less than 2 will
yeah. So less than 2 centimeters or 2 to 5 centimeters. So it is. Um, so are you saying that it is going into stage two T2B? You mean?
no, sir, it will go, if it is equal to 2 centimeters, I mean,
Uh,
up to 2 or less than or equal to 2 is 2,
yeah, yeah.
1B only, so stage 1B only it comes under, with
Uh,
no lymph nodes, and up to 2 centimeters is 1B. If it is greater than 2 centimeters, 2 to 5, in between 2 to 5, it
then
goes
it goes to
into
T2. T2.
T2
Yeah.
and stage 2. So
Okay.
here,
So I think so. Then it will be stage 1B. You mean?
yes, sir. If you are considering it as this in
stage 1 it will.
1B.
Okay. I think she is right, Praveen.
Sir,
Praveen, what is the size of the breast compared to the size of the tumor?
breast was larger in size, sir.
This one, it's not a small breast, no?
No,
It's
sir.
a normal size breast.
Normal size for us.
Okay, right. Anybody else, Ainas? Any questions or clarifications you want?
No, sir. No, no, sir.
Okay, right. How will you proceed now? I think because Praveen is presenting, we'll ask him only all the questions. Praveen, how will you proceed with this patient
Yes, sir.
once she's come to you?
Yes, sir. I like to do investigation to confirm the diagnosis first, then to assess the stage of disease, then to assess the patient's status for the surgery. To confirm
Okay,
the diagnosis, we'll be doing the triple assessment, which includes clinical examination and history taking, which I have done already. Next, imaging. I like to do the imaging by mammography and to histology confirmation by image guided true cut biopsy.
okay. Image guided may not be necessary because it's a fairly obvious lump.
Okay, sir.
Image guided will be usually required if the lump is very deep seated or you are not obviously able to palpate it. If it is a radiologically irregular or abnormal area, then image guided. If it is a cystic or on if there is mixed echogenicity, then you want to see whether you want to get the solid component, then you may want to do a image guided biopsy. Otherwise,
Yes.
I think this is fairly straightforward. You can do a true cut biopsy of the thing. Okay, so will you do sonomammogram um, or regular mammogram?
In this patient, mammogram will be preferred, sir.
Why?
Sir, as she's 49 years old, fatty content will be higher, sir, which is
No,
more
it is not the 49 years old. How many years since menopause?
3 years back she had 10 menopause.
So that is a crucial thing.
Yes.
So it is not about age. There are 55-year-old women who still have periods. So in that case, see, the breast is still active, because every time there is period, that means that the hormonal changes are happening in the breast, and then the breast tissue is active. And so, you may not, the breast tissue will be dense, and you may not be able to appreciate any abnormalities. So that is why you do sonomammogram in such people. But when the patients are postmenopausal, I think you should do a normal mammogram or a digital mammogram. So what are the things you would want to see in a digital mammogram, Praveen?
Sir, If it is a malignant one, it shows irregular spiculated lesions
Okay.
and architectural distortions will be seen.
Okay.
And if any lymph node enlargements and
Lymph node may be seen in the
microcalcifications
axilla. May be seen in the axilla. Okay. What else?
and microcalcifications can be seen.
Calcification inside in the lump itself,
Breast.
and then the
Yes, sir.
microcalcification around.
Yes, sir.
So, in indicating presence of a
Malignant lesion.
DCIS,
Yes, sir.
the carcinoma in situ.
Yes, sir.
So, in the background of extensive, um, all those things are extremely important, because if there is a background of multiple, calcifications indicating presence of significant carcinoma in situ, it will change your management, right?
Yes, sir.
What else will you see in the mammogram? Nikita, what else will you see in the mammogram?
Sir, is there any distortion we'll see, sir?
That he has already said: architectural distortion, irregular spiculated calcification, and microcalcification. He has said all those things. What else will you want to see?
The if the mass is already present, the margins of the mass and
Yeah, he said
extent of its presence.
irregular spiculated. So it will, that is, description of the margin of the mass.
The next thing would be about the lymph nodes, sir.
Again, he has said all that.
So whether it is multifocal and
Correct.
multicentric.
So, multicentricity and multifocality has to be seen. Sometimes you may not have a palpable tumor, but you may have multifocal lesions. And what else will you see? Anybody else?
Any other mass?
That we have said. Just now we said
The breast.
multifocality.
Other breast.
Multifocality. Huh?
Other side of the breast.
Correct. You need to look at the other breast, which is in this case right breast. So see if there is any lesion in the right breast also. Okay. So then you have done the mammogram.
Sir, can I ask 2, 3 questions, sir, to Praveen?
Yeah. Of course.
Praveen, what are the views that you will see in a digital mammogram, Praveen?
Praveen, tell us, how do you do the mammogram?
So, X-ray plate will be fixed to the wall. Against the wall, we'll be asking the patient to press on it. Sir.
No.
Yes.
No, nothing. No pressing on the thing or anything. The
No, it will be
mammogram,
placed.
mammogram is done by anybody? Nikita.
Sir, breast will be placed on a table or what is X-ray sheet, sir. Breast tissue will be compressed between the two beams.
Not beams,
Which is the
jaws. Yeah, it is
two
like
jaws. Yes.
yeah. So it is breast compression. I think what you have to understand is it is a very painful procedure, which is another reason why you don't do it in the premenopausal women, because again it is less sensitive, of course. And then, so for the sake of knowledge of the youngsters who have just come, Nitya,
Yes, sir.
you explain to them how mammogram is done. Why is mammogram not indicated in premenopausal women? All these things.
First, the indication, because in premenopausal women, the breast tissue is more compared to the fat. So for that, the sensitivity of an ultrasound, that is sonomammo, is better. Whereas one postmenopausal women, the fat is more compared to the breast tissue. So the digital mammogram is better. And like how sir said, there will be 2 plates of X-ray sheet. So there are 2 views in a mammogram. One is a craniocaudal view and another one is the mediolateral oblique view. So in craniocaudal view, it will be the plates will be pressed in vertical position. Like the breast will be there, one plate above and one plate below will be there, and that will press. In mediolateral oblique view, the axilla will also be covered in the mediolateral oblique view. So it will be placed in a diagonal position.
Okay.
And
So
the another thing is mammogram is something like a screening tool for breast pathologies.
Likit, did you follow? Have you got any doubts as to how
Yes,
a
yes, sir.
mammogram is done? I think
Hello?
both of you have to go and observe how a mammogram is done. Okay?
Okay, sir.
You need to go and see, just describing it, theoretically is not good enough. You have to practice and see it, in real life. Okay? Request the radiologist, Dr. Shravanti,
Okay,
uh,
sir.
and go and watch it. Okay? So see how
Okay.
it is
Yes,
done.
yes,
Okay,
sir. Yes,
so,
yes, sir.
did you follow? The breast tissue is very dense in the premenopausal women, and hence lesions that are there will not be visible. So my
Yes.
calcification and even a tumor may not be visible, which is why you rely more on a sonomammogram.
So,
So how is sonomammogram done, Nikita? Nikita,
Hello, sir.
how is sonomammogram done?
Sir, along with the mammography,
No, you're not
the
doing it
breast
along with
ultrasound is used.
mammogram. You're not doing it with mammography. Mammography is not
It's
done at
complete.
all in premen. Sonomammogram
It's
is
an
different.
ultrasound.
How do you do sonomammogram? What do you use?
Uh, like ultrasound transducer only, sir. Like how
Yeah, agree. But what transducer?
I don't know the exact variant, sir.
No, it is very simple, ma. It is the breast in surface tissue or is it deep tissue?
Surface tissue, sir.
So what do you use? What
Low frequency.
High
not low
frequency.
frequency, high frequency probes. So it is something like 7.5 to 12, even 15 megahertz probes that are used. So, for the surface, you have to use the high frequency probes.
Okay, sir.
Okay. So, and then you look carefully to see what are the things that you see.
Sir, we look for the lump, the surrounding nature, and
Usually,
the
the lump will be what? Will it be hypoechoic or hyperechoic?
sir, malignancy would generally be hyperechoic.
Hypoechoic. Okay. Generally, it is hypoechoic. If it is a cyst, what will you see in the cyst? If it is a cystic swelling, what will you see?
Hypodense collection, sir. The
It's not
shadow.
dense. It's not dense is different. See in
Homogeneous.
Hypoechoic collection with a
you have to
shadow,
if it is
acoustic shadow.
fluid, you have to see whether it is a mixed cellularity, whether there is both liquid and solid component. Is the cyst irregular or regular, and vascularity. So all of these things will tell you whether it is just a simple cyst or a complex cyst or a malignant cyst. You can have malignancy in cysts also. So you need to be careful about it. Otherwise, it is a hypoechoic mass which is irregular and with calcification inside the tumor. And also you can have calcification also visible elsewhere on sonomammogram. And then obviously you will look at the lymph node also, and axillary lymph node. The same principles apply. One is the size of the lymph node, anything greater than 1 centimeter, assume significance, then taller, then wider, then loss of architecture, loss of corticomedullary differentiation, and matted nodes, multiple nodes, increased vascularity around the nodes. All of these things indicate malignancy. So, you in sonomammogram, the added advantage is you can also assess the axilla properly. Any questions?
No, sir.
Okay. Praveen, how
Yes,
do you
sir.
do a true cut biopsy?
So, we'll be using the 11 gauge needle, sir. And a small stab incision will be made, sir.
Uh,
The skin.
First, you have
And
to give local anesthetic.
local
No?
anesthesia. Yes, sir. Yes.
Who is going to
We'll
do
give
it? See,
wings.
when you are asked about that, you have to mention first. You have to take the consent from the patient. You should convince and counsel them about.
Also profession.
It causes a little bit of pain, but it is necessary to do it. So always do the the incision wherever you are going to make it should be in the line of the potential line of incision for
Incision.
the complete excision of the tumor.
Yes, sir.
Always it should be in that line so that it will be part of the incision
Yes,
later.
sir.
Okay, then give local anesthesia, then make a stab incision, and then introduce the
Core needle biopsy. 11 gauge core
and the
needle
core
biopsy.
needle and take biopsy.
Yes, sir.
What is the advantage of core needle biopsy over FNAC?
Sir, it can differentiate between non-invasive and invasive, sir. And hormone receptor immunohistochemistry can be made out, sir, from those tissues.
They are now even to do that with even cytology, because cytology is also becoming good. But I think the advantages are what you have mentioned, that you can get the grade of the tumor, you can get the uh, histologic type, can also get the hormonal receptor status. And what else? What else do you see? Will you see in the way true cut biopsy? What index?
Yeah,
67
67.
index, sir.
A67 index. So all of this you will be able to get from the thing. Okay.
Yes, sir.
So now this is a um, early breast cancer. Clinically no axillary nodes. What other do you need to do a metastatic workup in this patient? Praveen.
To stage the disease required, sir.
Yeah. No, but why do you this is early breast cancer? No, why do you want to do metastatic workup? Huh? Nikita.
Sir,
I-
first, as a baseline investigation, we need to get it done, sir, to see the response
Correct.
later on.
You need to have a baseline. Yes. Then what else?
And if we do an ultrasound and if it shows lymph nodes, maybe that will indicate more for the metastatic workup, sir.
Okay. Then what else? Nitya, why do you need to do metastatic workup in this patient? It's early breast cancer, no?
To start
Sir,
neoadjuvant or to go for surgeries.
Huh?
Sir, to plan whether we have to go for neoadjuvant therapy or the direct surgery.
Correct.
the
That is
thing
one.
is here, if the patient is giving history suggestive of metastasis, then we need to extensively evaluate, sir.
No,
Otherwise,
no, 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 no. Don't touch. See, any tumor more than 1 centimeter is systemic disease. So that is the principle now, which is changed the approach to breast cancer. Previously, it was That is why radical and more radical surgeries used to be done. But then the concept of breast conservation came in because a tumor of 1 centimeter size is deemed to be a systemic disease. Less than that may not be. So here, when it is 2 centimeter by 2 centimeter, you are duty bound to exclude any metastasis. As Nikita said, she's made several good points. One is you need to know the baseline. As if for example, 2 years down the line, if some liver mets appear, let us say for example, you don't know whether it was already there or it's just come recently. So, which is why you need to have a baseline investigation. So, the current accepted baseline at this level will be a HRCT of the lungs. No longer is a chest X-ray acceptable because HRCT is going to give you better, delineation of any lung metastasis. So, HRCT is now accepted standard. Then you need an ultrasound scan of the abdomen to look for. Samir, what are the things you look for in an ultrasound scan of the abdomen? Samir,
Liver mets, sir.
liver mets, yes. What else? Ainas,
Sir, ascites, sir.
ascites, correct?
Uh, yes, that's all. Like, sorry.
Ovarian.
Nikita, Praveen,
Sir,
let Praveen answer this.
Lymphadenopathy also, sir. Like,
Correct. Lymphadenopathy, ascites, and what else, Praveen? More applicable to more advanced disease, but Krukenberg tumors. Any ovarian cysts or ovarian tumors you can pick up. And the rest of it you mentioned ascites, liver mets, and lymph node metastasis. So ultrasound, baseline ultrasound, and HRCT. This I think the bone scan is in this lady probably not indicated, but I want you to go through the literature and post it in the group whether a bone scan is indicated or not. Probably it is indicated. I think it forms the part of the workup, but just check because I don't want to mislead you. I think bone scan is probably indicated, but check and put it up in the group.
Yes, sir.
But if, for example, if there is already any evidence of metastasis elsewhere, then you are well within your rights to do a PET CT.
Yes, sir.
Otherwise, PET CT doesn't form a baseline, metastatic workup as far as breast cancer is concerned. Only if there is clinical evidence of metastasis, then you can. Why do you want to do it then, Nikita? If there is clinical evidence of metastasis, let us say there is some ascites or pleural effusion or something. Why do you want to do PET CT?
so to see the extent of metastasis, sir, to see
See,
what all other organs are involved
correct.
and
It can be,
aging.
if for example, if it is caused pleural effusion or lung mets or whatever, then it would have probably caused brain mets or
Brain.
bony mets and things like that. So you might, and instead of doing several CTs, brain CT, CT of the abdomen, CT of the lung, and then bone scan, and I think the PET CT is probably more sensitive than bone scan for picking up bony mets. So it is better to do a PET CT only in those circumstances. It's not standard of care as far as the routine metastatic workup for breast cancer is concerned. All of you be clear. Exams don't go and say PET CT first. Examination say purposes HRCT for lungs, ultrasound scan of the abdomen, and bone scan. That is the three metastatic workup. And then what else would you do, Praveen? You confirmed the diagnosis. You have confirmed, you've done all the metastatic workup. What else do you want to do?
We'll assess the fitness of the patient for surgery, sir.
Yeah, then she has no comorbidities, so you can do routine workup for fitness for surgery, hemoglobin and LFT and all those things.
Yes, sir.
Okay, so you have now done all of those things. How will you proceed with this lady?
To plan for breast conservative surgery, it's central lymph node biopsy followed by radiotherapy, sir.
Okay, so describe to me how would you do a sentinel node biopsy?
Sentinel node biopsy, it is we can use of three types, sir. Technetium 99 imaging or methylene blue or by ICG, sir. If it is by methylene blue, then I will be injecting perioral injection and will be massaging the nipple areolar complex for 2 to 3 minutes. Then after 10 minutes, we'll be dissecting the axillary fold and we'll be looking for we'll trace the lymphatics with the dye state. Then the lymph node which was first identified from the tracing will be taken out for the frozen sections.
Okay, good. So far you have said it correctly. Nikita, is he completely right or is he wrong?
I think he's right, sir. Uh,
Okay, you are also you're partially right, both of you. Nitya,
I think he's right, sir.
see, this is where the power of observation comes. How many lymph nodes do you need to remove for a proper sampling?
4 to 3, sir.
2 to 3. So what did you say? You said the node that is taken up the dye you remove. So you have to remove
Yes, sir.
several other glands around it, which sometimes it may not be visible. So what you have to do is to remove the lymphoareolar tissue in and around the node that is lit up, so that you will have a no sampling error. Okay,
Yes, sir.
so that right. So that is the methylene blue. What is its sensitivity and specificity?
Sensitivity 85%, sir.
Uh,
Specificity around seems like 87, 85 to 87%.
Specificity is a bit higher.
Yes, sir.
Nikita, what is the sensitivity and specificity? Nikita, are you there or you gone away? Hello? Nikita, are you there? Nitya, is she there or has she gone somewhere?
I think she must have gotten a call or something, sir, because she's there in the meeting. Maybe she must have gotten call, I guess, sir.
She's attending the call. Okay. Nitya, what is the sensitivity specificity?
Um, I'm exactly not sure of the numbers, sir.
Okay. I think again worthwhile putting it up in the group. I won't, always spoon feed all the details to you. I see this one, radionuclide scan. Who's going to explain? Praveen, how do you do radionuclide scan?
Sir, we'll be using 99 technician sulfur colloid, sir.
Uh,
On the previous day or on the morning of the surgery, we'll be injecting it, sir.
where do you inject it?
Technetium 99. Same in the perioral region, sir.
Are you sure it's perioral region?
Sir,
Yes,
in and around the lesion, sir, lump.
Okay. Then what else what do you do?
Same with the help of gamma probe, we'll be tracing the lymphatics, sir.
Uh,
And with the with the highest intake lymph node, we'll be taking it as central lymph node, sir.
okay. So again, you have to remove 2 or 3 nodes along with it.
Yes, sir. Yes, sir.
Okay. What is the if you do, can you do a combination of both dye and this one?
Yes, sir. Both
I
of
think
them has highest specificity.
that is got us 95 to 97,
95% to
90,
98%.
98% up to 98% positive predictive value.
Yes, sir.
So you can do the combined one.
Yes, sir.
What about the ICG?
So ICG similar, sir. We'll be injecting in the perioral region and using the near infrared imaging, will be detecting the lymph node which had taken the ICG dye. 2 to 3 lymph nodes will be sending for the sample, sir. Its specificity is 87 to 90%, sir.
They're all similar.
Yes, sir.
Okay. Right. So you do sentinel node biopsy. Now describe to me how will you do the breast conserving surgery?
White local excision with at least 1 centimeter of clear margin, sir.
Okay. Where will you place the incision?
Circumareal incision, sir.
If depending on the
Location of
the accessibility of the lesion, you have to place the incision.
yes,
If it is easily accessible through circumareal, you should. But you also have to include the previous true cut biopsy or a FNAC site.
yes, sir.
It is very important. Okay,
Yes,
so
sir.
that you have to mention. That
Yes, sir.
shows that you are aware of the possibility of skin deposits while taking biopsy.
Yes, sir.
Okay,
Yes, sir.
so you have to include the incision. The incision should include the previous biopsy site. Okay, so you make the incision. You take a 1 centimeter margin all round the tumor. So that is, if at all it is a isolated tumor. What if there is microcalcification and things like that? What can you do?
They send for frozen section to check the margins free of disease.
You can do frozen section, but you can also do something else. What can you do, Nikita?
Sir, on table sonomammography to uh, find the minor lesions and cover them within the sample, sir.
You can do on-table sonomammogram, or you can even take a
Smart. Yes, sir.
specimen radiography and see if all the lesion that is being depicted has been taken out and anything is left behind.
Yes, sir.
More so if it is only microcalcification and a subclinical radiologically detected nodule, that then it becomes even more important. Then you do what is called as the guide wire. You radio, you have to place the guide wire onto the tumor. That is on the day of surgery. You it comes with clips. So basically, the radiologist will place the guide wire onto the lesion. So you remove the margin with the guide wire and take the specimen and get it imaged in the radiology department to ensure that all the microcalcification and everything is actually excised. So after you have excised, Praveen, what do you do?
It is central lymph node negative, surgery
Huh?
will be done. If central lymph node is negative, then the
Surgery will
excision
be
will be
done, but
completed, sir. Yes, sir.
you also are required to take cavity biopsies from the after you have excised the tumor to ensure that there is no margin involvement. You also have to internationally there is a code as to how you should label the specimen.
Short superior and long lateral, sir.
So you have to make sure that you label your specimen properly so that the radiologists are able to say if at all any margin is involved, which margin is involved. So that is very important. Okay,
Yes, sir.
so if for example sentinel node biopsy comes as positive, then you have to go ahead and do a axillary
Axillary
node
clearance.
dissection. So how do you do axillary clearance? What levels are you clearing here?
Should clear the level 1, level 2, and level 3, sir.
Not level 3, man.
Sir,
Level 3 is
level-
you don't have to. Level
Yes.
1 and 2.
Level 2, yes, sir.
Only level 3 is in only specific circumstances. So what you have to do is to wherever the incision you have made in the axillary crease, deepen it and remove carefully all the lymphoareolar tissue in that area along. You have to bear the axillary vein. You have to preserve the nerve to serratus anterior, nerve to latissimus dorsi, and the blood vessels. You can sacrifice the intercostobrachial nerve and remove all the lymphoareolar tissue, and the axillary vein has to be laid bare. You don't have to go between the two pectoralis major and minor to those that will form the level 3 nodes. So you don't have to take that out. Level 1, 2 will be sufficient. Okay, so you have done the axillary node if required axillary clearance. What is the advantage of sentinel node biopsy, Praveen?
Sir, we can avoid the axial lymph node dissection, sir.
So
Which
why will you
causes,
want to do that?
So, because as we are planning for breast conservative therapy, patient
No,
requires radiotherapy.
breast conservation has got nothing to do with sentinel node biopsy. They are two
Yes,
different entities.
No, sir, patient will be requiring radiotherapy. If patient undergo an axial lymph node dissection along with radiotherapy, then patient has more negative effect of lymphedema, sir.
So that's what you have to, this one, see, lymphedema and, seroma in the axilla for a long period of time. And then sometimes axillary vein injury, a hematoma, seroma, nerve injury, and then the numbness of the axillary skin. All of this, quite significant morbidity. So
Yes,
you can
sir.
avoid that. And
Yes.
other thing we have to say is that now sentinel node biopsy is such that even if the node, that is, as we said, it's about 95 to 97%, the predictive value is there. And even in those people where you might miss, micrometastasis in the nodes, it can be dealt with by giving auxiliary radiation chemotherapy also. And even if metastasis is detected at a later date, it doesn't affect the disease free or overall survival. So for all these reasons you can avoid doing axillary node dissection if sentinel node biopsy is negative. Followed?
Yes, sir.
Any doubts?
No, sir.
Okay. So after the, if node, if the, what will you do if margins come as positive?
Sir, I have to do the redo the surgery, sir. Excision.
Yes, depending on the histology, the grade of the tumor, vascular and lymphovascular invasion, and all these what will you say? It is safe to say in the exam that you would want to go back and redo surgery, and in elderly people, because you are going to give radiotherapy anyway, you may want to give a boost radiotherapy to the bed, so that will take care of the any micro metastasis, that is micro, what shall we say, residual disease that is there in the thing.
Yes, sir.
But in younger people, where with prolonged life expectancy, you don't want recurrence to happen, so you may want to go back, and that is why it is important to label the margin, so that you know which margin is involved, and then you go back and you can actually do a frozen section at this time, so that you ensure that you have removed everything.
Yes, sir.
You can also do the frozen section even in the primary setting
Yes,
also, if you have the facility to do it,
yes,
so
sir.
that you ensure that the margins are clear. What is
Yes.
the difference between frozen section and final histology? Anybody knows?
Frozen section only comments about the presence of malignant features, sir, not
Huh.
exactly the grade and
No,
histologic type.
yeah. No, but in terms
And
of the
margin
margin positivity, the difference,
after
what I
fixation.
what I mean is how many margin positivity cases does frozen section miss compared to the final histology? If you know the answer, you say it. Otherwise,
No, we'll look it up, sir.
you have to look it up. Okay. See, I can't give you all the answers. It is not fair. You need to work on these things. Okay.
Yes, sir.
So you have to find out the difference between the final histology, that is a gross, the this one, the I think it is called the final histology, and frozen section. Okay. So we have talked about margin positivity. We have talked about the axillary node, and all the metastatic disease. Now, after you have done this, let us say this lady is node negative, but with some aggressive features, even though the size of the this one tumor is 2 centimeters. So she is postmenopausal. How will you treat her? Is there role for neoadjuvant treatment in this lady before you take her up for surgery?
Adjuvant node also.
Huh?
Neoadjuvant node also. It is
See,
early breast carcinoma only
possibly because
requires.
it is less than 2 centimeters, and with no clinically no nodes and no evidence of metastasis, possibly
Yes,
no role for neoadjuvant treatment. So in
yes, sir.
between 2 and 5 centimeters, if on the histology there are some sinister features and things like that, you may want to do a neoadjuvant treatment before. So if at all you give neoadjuvant treatment, what will you do, and how will you when will you operate on this patient?
Neoadjuvant of 3 cycles will be giving, sir.
Huh?
3 cycles of neoadjuvant, sir,
What
followed
neoadjuvant
by,
will you give?
sir, adriamycin cyclophosphamide, sir.
What is current accepted standard? Is CMF
Standard
still the
is,
standard?
no, sir, FEC, sir. FAC or other is FAC, sir. FAC is 5-fluorouracil, adriamycin, and cyclophosphamide. FAC is 5-fluorouracil, epirubicin, cyclophosphamide, sir.
What about taxanes?
Sir, taxanes when there is head, sir.
I think taxanes are becoming first line treatment. I think you need to talk
Yes, sir.
to.
For neoadjuvant,
Adriamycin,
those will be given, sir.
cyclophosphamide, followed by taxanes will be given, sir.
Taxanes.
Paclitaxel or
Yes, sir.
docetaxel is given.
Doxycycline.
Yeah, so taxanes are becoming the first line treatment if they are, the Herceptin HER2 receptor positive, then obviously you have to give Herceptin with what else?
Trastuzumab based chemotherapy, sir.
Huh?
Trastuzumab,
Yeah, with what? Trastuzumab with
so paclitaxel, sir.
not paclitaxel. Today, who was there? Samir, you were there, huh? That lady Swaroop had come and was explaining to Sai Likit. Huh?
Perjeta also, Perjeta or pertuzumab also can be given, sir.
Pertuzumab. That's the one. Pertuzumab and
Combination of both
Pertuzumab and
trastuzumab plus
Tarastumab.
pertuzumab.
Yeah. It is supposedly much better than just giving individual Tarastumab. So, see, the thing is, there is, see, there will be constant change in the thinking. You are not wrong in saying you give 3 cycles and then do the surgery and then, complete chemotherapy. That is definitely one way. But also, what some of the oncologists think is, while you are giving chemotherapy, there is a group of cells or cell lines which are resistant to the given chemotherapy, right? And if give 3 cycles and then let it, and then do the surgery, in that meantime, the resistant, the germ line will grow and possibly metastasize. So, which is why you complete the course, the 6 cycles of the chemotherapy with the hope that the persistent bombarding of the with chemotherapy will make the tumor completely kill off all the tumor cells. So that is the thinking behind giving complete course of chemotherapy before doing surgery. So both of these are accepted. You have to gauge the response of the examiner, and you can actually mention it like this, that you can do 3 cycles of chemotherapy, then do surgery, and then complete the chemotherapy, or you can complete the chemotherapy and then do the surgery. So, what about hormone therapy?
Be using the tamoxifen therapy, sir. Modified estrogen, selective estrogen receptor modulator.
So, you can
If it is ERHR, ERPR positions.
positive, especially in postmenopausal women, you can still use tamoxifen. How long will you give tamoxifen for?
So 10 years, sir.
10 years. You can also use the anastrozole,
Luteinizing, yes, sir.
letrozole.
Oral
And,
aromatase inhibitors or
uh,
luteinizing hormone releasing hormone agonist.
what is that?
Coserelin, sir.
Oh, certainly. Okay. So, I think in the perimenopausal and premenopausal women with the ERPR positive, you'll go more for the letrozole or anastrozole. In postmenopausal women, you probably use tamoxifen.
Postmenopausal will be using anastrozole, sir. It is oral aromatase inhibitor, so it will block estrogen synthesis in adrenals, sir. So it is most effective in postmenopausal.
Then where will you use tamoxifen?
So tamoxifen you can use both premenopausal and postmenopausal.
Just, I think I know, I will stand corrected. So just check with Swaroop. Exactly, where do you use the tamoxifen and where will you use, are they interchangeable, or is there specific indications for using tamoxifen for using aromatase inhibitors and goserelin? Okay,
Yes, sir.
right. Now, how will you follow up these patients? So depending on the now, if the, for example, will you give chemotherapy in all patients in for a 2 centimeter tumor, or you just give radiotherapy to the breast and then give hormone therapy?
Radiotherapy with hormonal therapies based on immunohistochemistry.
So I think the standard is definitely radiotherapy to the rest of the breast, and if there is need, then you can give booster dose to the bed of the tumor if indicated. Then you you give them hormone therapy. But if there are features of it being a bad tumor, high grade lymphovascular invasion, and and all these things, and if there is this one multicentricity and presence of in situ tumors in such people, I think you should give chemotherapy. If they are perimenopausal and premenopausal, definitely you have to give chemotherapy. Okay.
Yes, sir.
Hello?
Yes, sir. Audible, sir.
Hello?
Hello, sir. Sir, yes, sir. Audible, sir.
Any doubts so far?
Not
No, sir.
exactly sure, sir. We have to, I think we'll read about this
Read
hormone
about what?
therapy is more in detail, sir. Little
Huh?
got confused there. Hormone therapies got confused there, sir.
Yeah. I think hormone therapy, what I want you to do is to first check whether tamoxifen and all these things, and the this one aromatase inhibitors and GHRH analogs, are they interchangeable, or are there specific indications for using them in premenopausal, perimenopausal, postmenopausal women? So you have to check that. And I think chemotherapy, whatever I have said is correct, but again, if you want, you can check that also. If there are bad features, certainly you have to give chemotherapy. That is, you are talking about tumors less than 2 centimeters size. 2 to 5 centimeters, there is no doubt you have to give them chemotherapy post-operatively, or you can even do neoadjuvant and then surgery. So both are acceptable. But the stage 1A, 1B tumors less than 2 centimeters, you I think you have to go by the histology. Look, if they are unusual tumors, if there is high grade, and if there is presence of lymphovascular invasion, all these things, then you are well within your rights to give them chemotherapy. So again, all these things, because these things keep changing, I think I go and talk to Dr. Sarup tomorrow itself and confirm all of these things.
Yes,
Follow up, Nikita. How will
Yes,
you
sir.
follow up this patient? Hmm? After the treatment is completed, what will you do? That is, they will be still on hormonal therapy, but you would, if at all they have given you have given radiotherapy and chemotherapy, you complete that. Then what will you do?
Sir, repeat PET CT we'll do every year,
Not
sir.
repeat. You have not done PET CT at all. So this will be the first PET CT, because till now you have not done a PET CT. Unless, as I said, if you are already suspecting metastasis or you have evidence that there is metastasis, then you do a PET CT before you undertake any treatment.
Yes,
But if you have not done a PET CT, then you do a PET CT now to have a baseline as to whether there is any evidence of tumor anywhere.
residual.
So and after that you don't have to repeat it if there is no evidence. Then you do standard ultrasound scan of the abdomen and CT of the chest, and I think sonomammogram to see if there is any evidence of local recurrence, and also look at the contralateral breast. So that is
Yes.
first 2 years every 6 months, and after that every year. Okay, so I think fairly standard. I think early breast cancer. Any questions or clarifications?
Sir, is there any possibility, sir, clinically we could be in stage 2 or T2, but final pathology report, can it come as stage 1 also, sir? Like the tumor size could be lower than the clinical estimation or the radiological estimation?
I think generally that won't happen, because what is clinically palpable and what is radiologically described will almost certainly be the similar thing to pathology. There can't be much difference between the two of them. So generally, it is what a clinical and radiologic stages will be similar to the pathologic stage. Only thing is, it could be worse than that, because if you have invasion of the surrounding tissue beyond the size, beyond the tumor itself, extra tumoral invasion, then it can become worse than what it was described clinically or radiologically. Ainas, any doubts, questions?
No, sir. No,
Samir?
Sir, according to the NCCN guidelines, sir, HER2 status does not alter the management of strategy.
What?
HER2 status, sir,
Uh,
does not alter the management. Why they have mentioned it, sir?
that is because if because I think it is all very clear. If it is HER2 new positive, then you can't give the rest of the chemotherapy. You just give them the trastuzumab with the pertuzumab. So the it is the management is fairly clearly stated. If it is HER2 new positive, if it is ER, if it is triple positive, then it is, and if it is triple negative, only then it becomes a major issue. If it is, what will you do if it is triple negative, Praveen?
Multi combination chemotherapy.
Chemotherapy. Yeah. So I think Nikita and Nitya, now tell us how did Praveen present, and how did he answer all the questions?
Sir, his history and examination was precise, sir. It was good. And answering also, he did uh, reasonably well, but he needs to be even more updated, I feel, sir.
I think he answered well. I don't
Yes,
think
sir.
there was any. I think Praveen, I have to say, if you answer like this in the exam, you will pass, because this was fairly straightforward. There isn't any ambiguity about the clinical diagnosis or whatever. But if there is any doubts and things, then you should be prepared to offer differential diagnosis. You should be prepared to offer the differential diagnosis in the right order and defend why you have said it is malignancy first and other condition next and all these things.
Yes, sir.
Clear? Followed?
Yes, sir. Yes, sir. Yes,
Okay.
sir.
Otherwise, I think you presented well and you answered the questions well. Keep this one, and all the doubts and all the debated points is one. See, I don't believe in just saying something without actually being absolutely sure about it, because what happens is, whenever in these classes, whatever we tell you for some reason remains in your mind, especially controversial things. And in the exams, if you go and say that, and if it is wrong, you will be unnecessary in trouble. So just check all the things that we have raised. Hope somebody has noted down all the, sort of, what shall we say, disputed points. Nitya, have you noted down?
Yes, sir.
Okay, right. So if there are no questions, well done, Praveen, and we'll close the class.
Thank you, sir.
Good night.
Good night, sir.
Thank you,
Good night,
sir.
sir.